great presentation, and we will leave all of the questions to the end. And now I would like to introduce Professor Karen Knapp. She is Associate Professor of MSK Imaging and Head of Department of the Health and Care Professions in the University of Exeter. And Karen is involved in many research and international projects, and will be great to listen to your talk. Thank you.
Thank you very much, Joanna. It's my pleasure to come here and talk to you about osteoporosis. These are my disclosures. In this session, I'm going to talk about the clinical risk factors for osteoporosis and how we can use those not only to triage our patients, to decide who needs imaging and who doesn't, but to help us better identify who should be treated. I will also be looking at how we can use our DXA scanner to identify patients with vertebral fractures, to better characterize risk, and also to look at a traumatic femoral fracture, atypical femoral fracture screening. So these are the clinical risk factors for osteoporosis. We know that people are more likely to sustain a fracture related to osteoporosis as they age, and those who have a fragility fracture over the age of 50 are likely to have osteoporosis. Females are more likely to suffer from osteoporosis than men, but that does not mean we shouldn't image our men. Those with a low body weight and those with previous fractures, particularly vertebral fractures, and we know that vertebral fractures are a very strong indicator for future fractures, both hip fractures and further vertebral fractures. Glucocorticoids have a profound effect on bone, and we should be monitoring bone density in anyone who's on glucocorticoids for 3 or more months. And we also know that aromatase inhibitors and androgen deprivation therapy patients also need to have their bones assessed. Rheumatoid arthritis and secondary osteoporosis, and there's a range of conditions here which I won't go through in detail, are also on the referral criteria. And there's some modifiable risk factors in current smoking and an alcohol intake of 3 or more units a day. We tend to use FRAX, and you can see here on the left we've got the FRAX outline. It's very quick, and most of our DXA scanners have FRAX within them. It uses a very small number of questions to calculate the fracture risk. On the right-hand side here, you can see Q fracture, which asks many more questions and tends not to be used clinically because it takes a little bit longer to complete. Both of them, however, give good fracture risk assessment based on clinical risk factors. In addition to FRAX, in the UK we have the National Osteoporosis Guideline Group, and this links into FRAX. We have an extra button down here on our UK ones. And if you press this, you get the graph on the right-hand side. And you can use FRAX both with and without bone mineral density. So here we have a 62-year-old female who's just had a fragility fracture and has no other risk factors. You can see here that the major osteoporotic risk is 14% and hip fracture is 3.1. And if we look at the NOGG guidelines, we're going to need to measure her bone density with DXA. In the UK, if people are over the age of 75, we could treat them without the need for DXA, although increasingly we're needing to use DXA now. We've got romosozumab, a new drug which has come onto the market recently. Here, if we then do a DXA scan and her bone mineral density at the femoral neck is 0.574, that gives us a T-score of -2.4. So under the WHO criteria, she isn't osteoporotic. However, if we put her clinical risk factor into NOGG, we can see here that she's actually above the intervention threshold. So we know that combining both bone mineral density and clinical risk factors gives a better prediction of fracture risk in the future and can better hone our need for treatment. So this patient would be put onto a first-line treatment with an oral bisphosphonate. So what other techniques can we use with our DXA scan to better predict fracture so that we can treat those who most need to be treated? This is an example of trabecular bone score, and this is an additional post-processor you can use from your DXA image. This predicts the fracture risk independently of bone mineral density, although I'd argue that because you're using a DXA image, it's not entirely independent. And it can be used to complement bone mineral density. This is the image you get here on the right-hand side. And this is doing a pixel-by-pixel analysis to identify the trabecular structure based on the imaging appearances in the DXA. It has low precision errors, and at Exeter we've actually done the work to demonstrate this, and they're broadly in line with those that you get for DXA, which is unsurprising because this is derived from DXA imaging. And this can be added to FRAX as well. Because FRAX is based on femoral neck bone mineral density, we often find patients who have a very low spine bone density but have a good femoral neck bone density are underestimated for their fracture risk. And so if they have a low TBS score, this goes some way towards adjusting the FRAX in our patients with low spine bone density. There are also some other adjustments in the latest NOGG guidance which you can do as a rule of thumb. Vertebral fracture assessment is widely used in the UK, and this can be done on most DXA scanners. And on the right-hand side here, you have a single energy VFA scan from a Hologic scanner, and next to it a dual energy from a GE Lunar scanner. And you can see on the dual energy that you get much better visualization of the thoracic vertebrae. This is about 1/100th of the dose of the thoracolumbar spine series, and so we can justify this on the balance of probability that the patient might have a vertebral fracture based on our protocol. So we tend to use a protocol of females over the age of 65 who have a T-score of -1.5 or below, and men over 75, and all patients over 50 who are on glucocorticoids, because we know they get more vertebral fractures. We get a single sweep from T4 to L4, and it has a very high level of accuracy, particularly for identifying moderate and severe vertebral fractures. It's not quite so good for mild vertebral fractures, but we also know that mild vertebral fractures are not as predictive of future vertebral fractures as moderate and severe ones. It's really important that we do pick up patients who have vertebral fractures, because we know they're an incredibly strong predictor for future fractures, both hip and vertebral fractures. And once a patient has 3 or more vertebral fractures, they have a 23-fold increased risk of having further vertebral fractures. And we know there's excess mortality as well as morbidity associated with vertebral fragility fractures. It's really important in the UK that we do onward imaging to characterise the fracture and make sure that it's due to osteoporosis and not due to metastatic disease, for example. So the final addition which we can have on our DXA scan is to look for atypical femoral fractures, and these happen in patients who are on bisphosphonates, generally for 5 or more years, and they occur due to oversuppression of bone turnover. And you can see on this here, there's about halfway down, we've got this little beaking in the cortex of the bone, and this is an incomplete atypical femoral fracture. These have a high morbidity rate associated with them, and they always require a femoral nailing. But actually, because they are very difficult to get to heal, a lot of repeat surgeries occur. Many hospitals will undertake prophylactic femoral nailing because the risk of these going completely is catastrophic for the patient. The software for these is not as accurate as actually doing a visual assessment, but again, further imaging is required. So in conclusion, clinical risk factors for osteoporosis are key to both triaging our patients, but also to assessing who should start treatment, and both FRAX and Q fracture are appropriate. The National Osteoporosis Society and Guideline Group give fantastic guidance to help us triage our patients for treatment. And additions to DXA, including TBS, vertebral fracture assessment, and atypical femoral fracture screening, are very useful additions to your service. Thank you.